Okay, hello everybody. I'd like to welcome you to this Society of Skeletal Radiology Resident Education Club webinar on the balance between private practice and academic radiology. My name is Andy Sonnen. I'm a former president of the society and now just an old member. And I'll be serving as the moderator for this session. I'd like to remind you for a couple of ground rules. Number one, if you do have any questions for our speaker, please post them in the Q&A module and not in the chat module so that I can see them and he can see them. And number two, there was a survey, or I guess a series of surveys to fill out. So please don't forget to do those at the end of the webinar because that's important feedback for the program. So at this point, it is my pleasure to introduce you to our speaker, who is Dr. Michael Trakhtenbroit from Texas. He'll be talking to you, as I said, about his experience with academics and private practice. Dr. Trakhtenbroit.
Thank you very much, Dr. Sonnen, for that introduction. I just want to say what a pleasure it is to be with you all this afternoon. This is a topic that I find very interesting, and I'm sure is very interesting for all of our residents, especially those getting ready to hit the job market. So we're going to go ahead and get started. First off, I don't have any relevant disclosures or conflicts of interest related to the topic on which I'm going to be speaking. So, of course, let me just tell you, who am I and why am I speaking? I think that's very important, is that, you should know the credentials of the person who's going to be giving you advice. So essentially, I'm a fellowship trained MSK radiologist. I currently work in Houston, Texas. I've been a member of a physician-owned private practice for the last 5 years. And our practice contracts with one hospital system called the Houston Methodist Hospital System. It essentially consists of about 7 hospitals with an 8th hospital on its way, about 10 imaging centers, and about 10 to 15 standalone ER and urgent care centers. And we provide the radiology services for all of it. Houston Methodist also has a radiology residency. It was actually in the works before I started my practice. And then when I came on, I was asked to help run the residency, which we started during my 2nd year of practice. We currently allow for 4 residents a year, and we also have an ESIR pathway. I serve as the director of MSK for the radiology residency, and I oversee the MSK section for our group and the entire hospital system. Houston Methodist and thus our residency is affiliated with the Texas A&M School of Medicine. And so I work a lot with our medical students and oversee the MSK curriculum as part of their rotation. And a little bit later on, I'm going to talk a little bit more about my role in the practice, which is more of a hybrid academic and private model. So why do I have this picture here? So when I look at this, I really see a beautiful landscape. And this was sort of how I felt when I was getting towards the end of my training, is that I saw something in the distance. I wasn't sure quite what it was. I wasn't sure what to make of it. And I thought to myself, I really wish I had some guidance to sort of, set the ground for what this landscape means and what the outlook looks for me. So let me go ahead and paint the picture of where we are in this COVID or post-COVID world, depending on where you are. So as of late 2019, there was an expected resurgence and continued demand for radiologists, which was said to at least go through 2025. Merritt Hawkins, if you're not familiar with Merritt Hawkins, it's essentially a physician and advanced practitioner recruitment firm. They predicted an increased utilization of radiology services based on, one, an aging population, and also a strong economy, which will only serve to increase the number of elective procedures. Merritt Hawkins also predicted that the increasing number of radiologists reaching retirement age and also combined with fewer trainees would constrict the supply of radiologists in the setting of a continued surge in demand. So then in COVID-19, I can sort of draw the picture of what it was like here in Texas. So March 2020 was when things started to essentially shut down. We saw a massive drop in demand in imaging services. At least in my practice, we were showing up to the hospital because we needed to obviously have the hospital staff with very, very little to do. We saw about, in some locations and practices, there was a decrease in volume of up to 80%. And then in October 2020, we started to see the pendulum begin to swing in the other direction. There was a significant increase in demand in imaging services for which the reasons I'll go into in just a few minutes. At the same time, due to an increased demand and volume of services, there was an increased demand on productivity requirements per full-time FTE employee or FTE, which has only continued to increase since that time. So this is from Frost and Sullivan. They're a very well-known marketing firm, and I really like this chart because I'm a radiologist. I like pictures, right? So a picture say 1,000 words. So essentially what we're looking at here is showing the rise of a lot of cross-sectional imaging. So CT and MRI examinations over the last 15 to 20 years. And we've seen a steady increase. At the same time, we've seen a corresponding increase in the demand for more radiologists. However, when we look at the dark blue line, which represents the supply of radiologists, we see that the two lines are only diverging more and more and more as the slope of the lines are different. And there are many reasons of why the supply of radiologists just hasn't kept up. But the fact is, this is where we are. The demand just continues to increase. We see more and more round-the-clock advanced imaging expectations, and we just do not have the radiologists to actually meet the demand currently. So here you are, you're at the end of your residency, you're standing on the edge of the cliff, you're excited, you're ready to take the jump off. And it's always a question of, where am I going? What are my options? And that's something I want to, now that we've sort of painted the landscape of what's out there, something that I want to spend a little time delving into further. So what are your options? Well, in the current radiology world, you actually have quite a few. One is going to be academic radiology, which tends to be hospital affiliated and you're employed by an academic institution. The other is you are going to be hospital employed by a hospital which does not have an academic affiliation, and you may be part of a physician's organization. Third option is the traditional private practice model, which is physician owned. The fourth model is a for-profit third-party finance corporations. These tend to be things like practices and corporations that are backed by private equity or venture capitalism. And lastly is teleradiology. So academic radiology, it's one of those things that when we're in training, we get used to seeing. It's easier for trainees to understand academic radiology because they've been working with attendings who are part of academic radiology for the last 4 to 5 years. We have started to see trends in academic medical centers towards larger departments whose members are employees of multi-specialty medical groups. And the key thing that I want to sort of go into is that we do have classic generalizations and classifications which apply to academia and private practice, but the lines have started to be a little bit blurred, okay? So even though all radiology jobs are different and lie in different spaces on the academic private spectrum, we can make a few generalizations on what it typically means to be considered in an academic position. So in academic radiology, you have a mission of the department, right? So and the expectation is that all members of the department are committed to that mission. Most academic groups provide their radiologists with time to pursue their interests, whether that be research, education, informatics, public health, public policy, and so on and so forth. Academic time is often given, but it's often uncompensated unless there is a specific academic compensation plan in place. In general, academic radiology has a strong commitment to education and teaching. And compared to private practice, there is a much stronger demand for a higher degree of subspecialization, although in my opinion, I do think that's changing over time. In academic radiology, salary and paid time off are generally less than private practice, but of course it's going to vary on geographic location. And in general, in academic radiology, you have a complex governance system, with an actual radiology chair who sits with all of the other chairs as part of an academic medical center. And because of that, it may be difficult for other members of the department to necessarily implement changes to the overall practice of the academic radiology department. So what about private practice? Well, in general, I can tell you things vary widely in private practice. Groups may have contracts with hospitals and imaging centers. Groups may own their own imaging equipment or even own their own imaging facilities. And many groups are still physician employed, or sorry, excuse me, still physician owned, but groups may be employees of the hospital or a larger medical physician group. And why is this an important thing to distinguish? Well, the key difference in these different categories of private practice types is whether or not a practice can collect the technical component of its imaging fee in addition to the professional component. So what do I mean by that? For for some of you all who may not be familiar, is let's say we order an MRI at the hospital at which I work. The hospital at which I work, the hospital system owns the MRI magnet. So the technical component is essentially the built-in cost for owning the MRI, paying the salary of the MRI tech, paying the salary of the nurse who puts in the IV, and so on and so forth. The professional component is what the radiologist is going to be paid for interpretation of the examination. And as such, the technical component for any given exam is significantly higher than the professional component, okay? So I just want everyone to be clear on that. So a little about academics and private practice. So although most private practices have no academic responsibilities, there are some private practices, including myself, that are affiliated with academic institutions and have a hybrid academic private structure. Some radiologists may have academic responsibilities while others retain only clinical responsibilities. And in my opinion, I think that's good, especially if you're in a larger practice, because you could have a group of core radiologists who are committed really to resident education and teaching, whereas some of the other radiologists who are less interested can solely pursue their clinical responsibilities. However, in general, in standard private practice, there is much less emphasis on academic and research, but there is encouragement and many other leadership positions in private practice. For example, a lot of us sit on different hospital committees. A lot of us sit on medical executive committees and are involved in hospital administration. Since the hospital is our one contract, it is a way to sort of ensure that that contract stays firm and really have a good relationship with the people who are sending us business. So a little bit about group culture. I think this is something that's really important to think about, especially when you're out there applying for jobs. One thing to know is that group culture is going to vary widely. Okay, so traditionally private practice has been very high case volumes, although in academia we are seeing an increase in case numbers over the last years, and in some places case volumes in academia may be similar to case volumes in other private practices in the same geographic location. In general, some practices may try to run as lean as possible with high volumes required of each radiologist. In doing so, however, you have less mouths to feed, so to say, and therefore can have higher salaries. Other practices may be more of what's called a lifestyle practice, whereas let's say they say, well, we really want to maximize our time off, right? So in doing so, we need to have a larger number of pool of radiologists, but in that way, there are more mouths to feed, so maybe partner salaries might be a little bit lower. Another thing is call scheduling. How does call work? How many weekends a year are you expected to work? How many hours are your call shift? How many holidays are you expected to work? These are all things that are part of group culture. Another one is overnight coverage. We're going to talk a little bit about that more in terms of radiology, but every practice does it differently. Are the guys who work days required to work some nights? Do we have an internal night team? Do we use a Nighthawk teleradiology service? Okay, and these all vary from practice to practice, and I think are really important for applicants to really figure these things out before they commit to a practice, so everyone knows what they're getting themselves into. So in general, salaries have traditionally been higher in private practice, but that depends on whether or not the practice is independent or it's employed, as well as the partnership structure. So in private practice, we have, quote unquote, multiple tracks. There's a partnership track, which, most practices will tell you that, you aren't on and what track you are being hired for, what the partnership track expectations are. Some practices may offer employment tracks, and some of these employment tracks will have incentive bonuses based on productivity. And then time to partnership is also going to vary among group as well as other geographic locations. If a practice doesn't have any issues hiring applicants, if they're in a very competitive location, for example, they may have a longer partnership track. You know, it really does depend on the state of the job market. So teleradiology. So this was previously considered less desirable, but I think, and it's my opinion, I think the opinion of others, that it's now considered a good option for early career radiologists, as well as a long-term career choice. As the push for around-the-clock subspecialty imaging grows, both private practices and academic departments, as well as third-party owned radiology groups, are constantly seeking teleradiologists. We have some very large private practice teleradiology groups in the United States, and they offer a lot of flexibility. They offer the opportunity to read your own subspecialty. They have competitive compensation packages, benefits packages, and time off benefits and vacation time as well. To some, there is the potential downside of social isolation and absence of interaction with colleagues. You know, I know some people who are in teleradiology, and one of their major concerns was, well, you know, if I'm working in a private practice and I have a question on a case, you know, who can I call? Well, really now with technology, all of these, I mean, we have them in practice too, but, you know, teleradiology, they have this great technology where you just push a button, you can see who else is working alongside you, and with a single click, you can push a case to a friend to have them basically look at it. And there are variable compensation models. Although some of the larger teleradiology groups are salaried, almost all of them have some degree of compensation based on productivity, aka WRVUs, or work relative value units. So the elephant in the room, you know, like I said, I'm a picture kind of guy. The million-dollar question is, well, you know, everything that you've talked about, what does this mean for me? Okay, so we're going to talk a little bit about that. So it's 2022, but I think we can't really know where we are in 2022 until we discuss where we were in 2021. And in 2021, we saw a significant increase across the board in imaging volumes. And why was that? It's a very complicated question with a lot of answers. Obviously, in my opinion, we did see a lot of delayed care during the peak of the pandemic. Patients putting off physicians' visits, patients putting off ER visits, patients putting off routine cancer screenings. And what this has basically led to was a massive increase in ER and urgent care visits. And in general, the ER and urgent care setting employs heavy utilization of imaging services, which results in a significantly increased number of exams. Also, we see that the country has largely reopened. People are traveling, sports are back, social events are back, and all of this results in an increase in radiology and an increase in ER services. At least, you know, as a musculoskeletal radiologist, you know, when schools were out and high school teams weren't going and professional sports weren't going, yeah, we saw significant decreases in outpatient MRI and CT, which has really come back in full force. May 13, 2021, the CDC officially lifted mask mandates, and a lot of practices actually have data showing that within 48 hours, I mean, you can get these from the hospital as well, there was a significant spike in ED visits and imaging volumes, which has only increased to where we are currently. The other thing is the aging workforce. It's one thing that I had hinted at before, and this is true of radiology, but it's really true of all physician specialties. So 2008, as many people remember, we had the global financial crisis, okay? And because of that financial crisis, we did have a significant number of physicians, among other professionals, who chose to delay retirement, and then this resulted in decreased new hires entering the job market. Some of those physicians considered retirement at the start of the pandemic, but as we remember from March 2020, when the stock market essentially bottomed out, there was a lot of financial uncertainty at that time. In 2021, the market, I think, outperformed expectations and did quite well, which has led to some aging physicians, including radiologists, deciding to retire. I think, you know, for some people, probably the relative increase in practice volumes and productivity demands has only further pushed that desire, because everyone is really feeling the strain of the current landscape of medical practice. So the current job market, you know, I have this picture of fire, and that's because, at least from what I've seen, from what I've heard, And in my opinion, it's currently quite a good job market. Practices are making a significant number of offers to bring in new talent. I know our practices, and I know a lot of other people's practices as well. And the competitive job market is not just for graduating residents and fellows. We are seeing a lot of lateral movement of radiologists in private practice, maybe moving from one private practice to another, or a private practice to academic, or vice versa. And what happens is that when you have a lot of lateral movement, you're going to have shortages in other academic radiology departments, as well as in other private practices, which is only going to drive demand for hiring new graduates. At the same time, we haven't really seen the commensurate expansion of residency positions to meet this demand. So therefore, I think, in my opinion, that we're seeing a really high demand for a lot of new graduates, and I think the market is very advantageous because of that. So in my opinion, like I said, the current radiology job market is quite strong. Why? Simple. It's supply and demand. It's basic economics. Okay, but even on top of that, we are seeing such a high utilization of advanced imaging. One of the things that we look at in my practice is things like RVUs per charge count. Basically saying, charge count is the same thing. If I read 10 chest X-rays, that's 10 charge counts, right? But a chest X-ray is only, let's say, 0.1 RVUs, okay? But we're seeing that ratio of RVUs to charge counts going up, and up. Essentially, what that means is that we're doing more and more high RVU imaging, which tends to be CT and MRI. Because of such, we're seeing an even higher demand in private practice for subspecialty radiologists to be able to read subspecialty exams really at all hours of the day. And in general, this has been tough on private practice, because private practice has always sort of been the general radiologist model. But radiology has changed so much that I think it's very challenging for any radiologist to be good at neuro, MSK, breast, pediatrics, nukes, and so on and so forth. Furthermore, there's this idea of round-the-clock imaging. I know it's a big thing at the hospital where I work, and essentially it boils down to the fact that hospitals, private practices, and academic institutions, they'll happily schedule patients for MRIs at all times of the day. If a patient wants a knee MRI at 10 p.m., they can get it. And for a lot of people who work, standard business hours, it's a very desirable option, including weekends and holidays as well. And from a standpoint of whether or not the practice owns the equipment or the hospital owns the equipment, anytime the machine down is basically money lost, okay? And because of such, there's a demand for constant machine uptime and machine utilization. So we're seeing a significant increase in after-hours imaging, including evenings and weekends. Now, is it always necessary for, let's say, a thumb MRI that's not urgent to be read at night or on the weekend? Probably not. But now we're seeing more and more exams ordered as stat. And certainly in practice, when you have contracts with a hospital or physician groups, there is definitions in that contract that are legally binding as to what stat means, right? So for example, in my practice, that means in general, and even though we have different specifications for things like head CTs for strokes or PE protocols for chest, there's an expectation of, on average, every stat exam that we read has to have a turnaround time of less than an hour, okay? And we even have, and a lot of practices have, mandated turnaround times for non-stat routine exams, okay? So just a basic knee MRI. And so these are something that you really have to be cognizant of because of your contracts to keep your contracts strong. So with that, I'm gonna briefly transition over to a little bit about my own practice, and the reason why I want to do so is just to basically put out there to our residents that even though we have these traditional models of private, nights, teleradiology, academia, there are some jobs out there. I'm not saying that they're the majority of the jobs, but there are some jobs out there which sort of blur the lines, okay? So my practice is technically a hybrid model. We have had fellows in our department for a long time, because Houston Methodist Hospital used to be affiliated with Baylor College of Medicine, and we used to have fellows rotating through. In our practice, we have both partnership track radiologists as well as employee track radiologists. And we also have our own internal night team of radiologists. So we do not use teleradiology. We have a rotating team of night radiologists who work 1 week on, 1 week off. And we also have academic radiologists. These are radiologists who, we have some who do a lot of research. We do some who do a lot of informatics. And for example, they get dedicated academic time, just like a radiologist at a pure academic medical institution would. So essentially, even though I work as part of one big practice, I think it's essentially more like an academic model where it's multiple practices within a practice. So we have a dedicated body division, a neuroradiology division, an interventional radiology division, a nuclear medicine division, as well as a night team. Within the body section, we have a team of musculoskeletal radiologists. All MSK MRI and advanced MSK CT are read every day by a fellowship-trained musculoskeletal radiologist. We literally have a position on our schedule that's filled by an MSK guy every day, and his entire job is to make sure that those exams get read. We even have some academic MSK radiologists as well, who rotate through, who do the same rotations as our other MSK radiologists, but are more involved in, let's say, MSK research and help run the MSK section of the residency and the medical student curriculum. And even on our night team actually consists of 3 fellowship-trained MSK radiologists, and I'm going to talk about why that is in just a couple of minutes. So, due to that increase in volume of after-hours CT and MRI, one of the things our night MSK radiologists really enjoy is the high volume of advanced MSK that they actually get to read. Depending on with whom they may be scheduled with that day, whether or not some of the other later evening radiologists read MSK, they may read 20 to 25 MRIs per their 9-hour shift, okay? Beyond, in my practice, that dedicated MSK radiologist, we still have many other MSK radiologists who are on staff during the day, but interpreting the MSK examinations is not their primary responsibility, but they're able to do so when time allows. In my practice, our MSK radiologists are expected to do the full gamut of general body radiology, including X-ray, CT, MRI, ultrasound, as well as fluoroscopy. So, one of the reasons that I chose the practice that I did was that it is a very high volume MSK practice, and that's one of the things that I'm most passionate about. It predominantly is sports and general orthopedics, but slowly we are expanding in rheumatology, orthopedic oncology, and one of our new additions that I've been spearheading is MR neurography. We treat a lot of major league and professional teams, multiple colleges, and in Texas, high school football is king. So we have these Saturday morning football clinics that the hospital runs, where people who get injured can come in, they can get examined, and then they can pretty much get an MRI, which of course is ordered stat. And it is an example of why every weekend that we schedule call, we actually have to have a dedicated MSK radiologist on call every weekend. So I believe that's all I have for you guys today. The reason why is that I wanted to leave a lot of time for questions. I think that this is a topic that I think is very, it's very challenging for applicants to navigate. And I really do want people to be able, for this to be an open forum to people ask questions, because really it is a major decision and a major point in your life. You've worked really hard getting through med school and getting through residency, and you're going to work hard through fellowship, and it really behooves you to do your due diligence and to do your research and ask all the questions you need to. So thank you very much for your attention.
Well, thank you, Dr. Trakhtenbroit. I see one question already on the Q&A post that says, how do practice models inform opportunities for MSK radiologists to do intervention/procedures?
Yeah, so let me go ahead and answer that. So yeah, so in general, anytime you have any sort of diagnostic exam being ordered, whether it's MSK or really anything else, there's almost always some procedure which can go along with it, right? So for example, I can give you a really good one. I did a lot of MR neurography as in my fellowship, and there's been a big demand in our hospital system around here for the last 5 years. And no one was doing it before I started here. And we've recently rolled it out through the whole hospital system, okay? And so now every day I have a list of emails saying, well, are you guys able to do this injection or that injection? Or can you block this? Can you do that? And the key thing was basically knowing that those questions would be coming and anticipating them and getting all of that set up as well. So yeah, so I do some MSK intervention. We have one interventional radiologist who did an MSK and an IR fellowship and specialize in all of that. So really, I think that the more you build the diagnostic aspect of your practice, you also build the interventional aspect of the practice almost at the same time. That's, speaking to some of the radiologists in our or some of the residents who may be going interventional, this is a constant conversation I have with some of my IR colleagues, which is how to capture some of the diagnostic business that we have and convert that into into an interventional business. A big thing is going to be lung nodules, right? We have all these lung nodules all the time, and some of them may require biopsy. Well, how do we know that we're actually capturing those patients for biopsy? So, I've seen a lot of different ways of doing it, but I know some practices, what they'll do is that, through the technology, you can actually flag a study. You can have one of your PAs or NPs review that study. You can have that PA or NP follow up with the patient's physician and be like, by the way, we just wanted to let you know that our radiologist is recommending a biopsy. Would you like us to go ahead and get that scheduled for you? And it's really amazing how appreciative a lot of our primary care providers are for that. And I think that just sort of anticipating any way to capture that business is a very, very powerful thing to do.
So I think it's interesting that you sort of proactively try to tee those things up based on recommendations in reports. Is that something, and I may have missed it, that you have an automated process to catch that verbiage and actionalize it, or whatever the word is?
Yeah. So for example, in our dictation software, we have like little flags, right? And so if I flag it, when I sign the case off, it'll automatically go to a person, right? So it's the same technology that if I read a case and there's an important finding, let's say it's not an emergency, but it's an outpatient who has, let's say, a fractured toe, right? I can flag it. It'll go to a specific person in our practice who will then call that practice, make sure that the report is faxed over immediately, and will document all of that. So the same technology that we can use for that, we've also used for this to try and capture more interventional business.
Okay, fair enough. So just so everybody knows, I did spend the first several years of my career in quote unquote pure academics at Northwestern University and then at the University of Maryland Medical Center, primarily doing sports imaging. But I've been in private practice since 1998. Which is before some of you were probably born. And I'm in a very large, I'm in 120 plus people, very subspecialized private practice group in Colorado. And so we, a lot of groups, I think Michael correctly said that a lot of groups do things in a lot of different ways, and we don't have time for me to go into all the details. But with regard to this question, it's interesting because we have 4 to 6 musculoskeletal folks who do pretty much all just musculoskeletal every day on the schedule. But because of the requirements of the way our practice is physically arranged, we're generally in outpatient offices. So we don't have the ability to do sort of high-end interventional stuff like bone biopsies or vertebroplasties. So in our practice, and again, your mileage may vary, but in our practice, we do the joint injections and the ultrasound guided procedures. And we do some lumbar epidurals and nerve root blocks and things like that. But the sexier stuff, the bigger deal stuff where you have to have somebody sedated or you have to have biplane, those will go to one of our hospitals where our interventional colleagues do them.
Yeah.
So again, it varies from practice to practice. A lot of my friends and associates across the country say, well, on my hospital day, I go in and do that. I basically don't have hospital days, but again, that's how my practice is set up.
Yeah. And and it varies, in general, it's similar in my practice where, if we're at one of our outpatient centers, yeah, we're going to be doing basic fluoro and ultrasound guided procedures. But if there is a higher level MSK procedure, what happens is that even before those get scheduled, it's discussed with one of the MSK guys. And if there's one of the MSK guys who really wants to do it, or requires a specific MSK guy to do it, then the schedule is automatically set up where that physician is put in the right location to actually do that procedure.
Right. And then the last thought I'll add to that is we tend to be very interactive across the practice in terms of, since we all feed off the same packs, we have a messaging system within the packs, and we share cases around, and it's not uncommon for one of the body guys or one of the interventional guys to say, hey, look, they're asking me to biopsy this. Number one, is this reasonable? Number two, how would you approach it? And obviously the first answer is talk to the orthopedic oncologist and find out what he wants you to do, which is usually modulated through those of us who are in MSK, because we have those relationships. So it's a team approach, but the hands on the patient will sometimes not be a fellowship trained musculoskeletal guy, only because of their physical location where the facility has the ability to do those procedures. So I hope that is a sensible answer to the person who asked it. The next question that I see is, and I'm going to skip around a little bit just because I'm trying to sort of keep some flow to the questions, do groups or employers view candidates differently when they use a headhunter type of service versus, I would assume, applying directly to the group either through reputation or through an ad that's in the ACR job listings?
Yeah.
Do you have any thought?
Yeah. So I would say that purely depends on the job market. And in my opinion, right now, applicants are in demand. And I think there are a lot of practices out there that are struggling with volumes, and they're struggling with people retiring. And from what I've heard from my own practice, but also other practices, if someone's qualified and the need is there, I don't think that they're going to be looked down upon. Maybe,
and I would agree. Yeah.
Maybe I think that may vary if the market changes, but right now I would say that the market is very favorable for applicants due to the need. So I really don't think it's going to affect the candidate in any meaningful way.
Yeah, and I would agree. I mean, anecdotally, again, having been involved in hiring people in this practice for over 20 years, I don't think anybody even asks, where did this candidate come from? We have one doc who at any given time is sort of our point guy for dealing with applicants and recruits and screening them essentially. And then it goes to, because we're big enough, just to the appropriate section. So the breast section, the nuke section, the ped section, for further vetting. And I don't remember ever asking or being asked, where did this come from, other than, usually my interest is, where did he train? Because I know someone that trained them. So I can get a personal reference. And that I would say, and this was not, I'm answering a question that nobody asked, which is in most larger groups, there's going to be a network system when you're looking at a job. In other words, they're going to dig into you. They're going to want to know where you came from, who trained you. And if anybody has any connection to anybody that's ever worked with you, they're going to want to talk to that person and get a personal, as opposed to sort of a generalized letter or a reference from someone whose opinion you don't know, has no inherent value to you. You're going to want to find out what one of your friends thinks. So that means two things. Number one, don't burn any bridges. In other words, just because you didn't ask for a letter of reference from someone that you didn't get along with doesn't mean that person's not going to be pinged about you. So you want to have a nice, clean, healthy background of your interactions with everybody you've come in contact with, because you never know which of those people is going to be asked about you. Does that make sense? Mm-hmm. I hope so. There's a related question back onto the interventional thing that I saw that I somehow managed to skip over, which is there a strong market for MSK radiology jobs that do not involve any procedures? Are these jobs pretty much only going to be teleradiology in nature?
No, I mean, I can tell you, at least in my practice, probably the majority of the MSK radiologists don't do any advanced interventions. Okay, we have some MSK radiologists who who do them, but the reality is and I know Dr. Sona could probably expand upon this, that we're a really large practice and we work at so many places that it's impossible to it's impossible to get an MSK radiologist at every place, right? all of our peripheral hospitals is basically a neurorad is there, a body radiologist who may or may not be MSK trained, and an interventional radiologist. At that hospital, the interventional radiology, whether it's a bone biopsy, a bone marrow biopsy, is going to be performed by an IR doc. If it's anything that requires ultrasound or fluoro, whether it's an arthrogram, an injection, or something like that, that's going to be performed by the body guy. And then the LPs and most of the spine work is going to be performed by the neuro guy. So at least in our practice, it wouldn't even be feasible. And in general, at least when we've hired MSK radiologists in the practice, in the past, most of them are not really required to really do any procedures unless beyond just the basic minor procedures, unless they really want to.
Fair enough. Again, what I'm trying to do is look at the questions and create a flow here, which may not always be totally smooth, but one of them is, based on your experience, what is the one thing you would advise us not to do as up and coming fellows looking for jobs?
One thing I would advise you not to do.
Kill any of your attendings. That I would definitely
yes.
not do that. No, I mean, seriously, this is about, right? This is about being a good team player, being someone that's pleasant to work with. I always say to the folks in my practice, look, this is a 30+ year marriage, right? You don't go on one date and say, this is perfect, let's do this. And you don't go into it without expecting a few bumps or hiccups, but it's a commitment. Yeah. And so we tend to be very, very, very careful about vetting the folks that are coming in.
At the same time, I think to correlate to that, one thing that I always tell people is that, it's very odd when you start to interview, you're very concerned about making a good impression, and understandably so, but that shouldn't get in the way of you doing your due diligence and asking the questions, right? And what do I mean by that? If you get a contract and you choose to sign that contract, you need to know every detail before you put your name on that piece of paper, right? There shouldn't be any ambiguity. You should know what your salary is going to be. You should know what track you're going to be on. You should know how much vacation you're getting. You should know how call is split up. And what I know from talking to people and friends is that sometimes, they say, well, is it going to look bad if I ask about money? And my answer is, honestly, I think it'd be stupid not to ask. I mean, these are the things that you really need to know. And so I think a mistake that's made is that in an effort to make a great impression is not digging and getting enough information about the practice to actually make the informed decision, and then just saying, oh, well, they offered me, that's wonderful, I'll commit to that.
Yeah, and I think you folks that are listening are in an enviable position in the sense that, as Dr. Trakhtenbroit said, for the foreseeable future, this is a seller's market. You guys are in the driver's seat in terms of there being way more jobs than there are applicants, and you won't be finding yourself competing for mediocre jobs. You'll be receiving multiple offers in all likelihood. So what I did and what I've advised people to do is to make an Excel spreadsheet or the program of your choice, and put down the things that are most important to you with regard to the job, and some of those are very meat and potatoes. What's the salary? How many years to partnership? How many weeks of call? That kind of stuff. And you will discover stuff as you go through the process. Oh, I should add that to the list. Oh, I wonder what that practice did because I didn't ask and they didn't tell me. I'll call them up and find out. So fill in that spreadsheet. And then when you're all done, number one, you won't forget what the details are if you do it right away as soon as you go. And number two, you can go back and maybe after talking to 6 or 8 practices, you'll have a better sense of which of those things is most important to you. And then you can sort of reprioritize your list and see which one, if objectively possible, makes the most sense for you. Do I want to live in this place? Do I want to work with these people? And it's not a perfect science. And again, like a marriage, it's not going to be, it's a great thing if something feels absolutely perfect, but don't count on that.
Yeah. And the reality too, I think too, is that life is give and take, right? So part of the reason why you should do, like Dr. Sonnen said, make a list of your priorities and prioritize your priorities, is that you may not get everything that you're looking for, right? Everyone wants the perfect job, right? And the reality is I think in general, people get a job and they're like, oh, well, the grass is always greener. So, now in saying that, if you say, I only want to live in this location and I have to be, near this family member and that's priority number one for you, then that's what you have to push for. But just like everything is a little bit of give and take. And so I think making a priority list is really, really key. I know that's what I did with my wife when I was applying for a job.
So I'm going to change gears a little bit and go back to one of the first questions that was asked, because it's sort of down a different path, and I think it's a really fascinating question. How do you know what one should go into when everyone is recruiting now as an R4, but you don't have any experience in these markets because you're from a small community program? And I'm going to editorially add on to that question. It doesn't matter what community you're in. You're a resident and you're already hearing about job offers. And I know that there are multiple folks that I interact with that where the groups are actively chasing R3s and R4s and offering them stipends during fellowships because it's that much of a seller's market.
Yep.
And it's hard. You're going to get to the point where you don't even know what fellowship you want to do and you're talking about job offers. So, I mean, have you guys dealt with that, Michael?
Yeah. So I get this question even from our own residents. They come and they say me and they tell me, what should I go into? And I'm one of those people that I believe that the best advice I got at that point, they said, I had an attending who said, well, which part of radiology could you see yourself getting up at 6 a.m. when you're 50 years old and still enjoying it, right? And so I'm a big believer in that, is that, if you get the best job in the world and you're hired to be, let's say, a nuclear medicine physician because you saw that the market for nukes was super strong, but you hate nukes, not even the best job in the world is going to make you happy. And that's honestly my personal feeling.
That 100%. And I can't stress this enough. Ladies and gentlemen, don't go into, for two reasons. Don't go into what's hot right now because it's hot. Number one, it may not be hot in 3 years. And then you'll find yourself with fellowship training that no one wants. And number two, as Michael said, and believe me, 50 is young anymore. You don't want to be 60 and waking up and saying, oh God, why did I choose to do this? I still love what I do every day. I'm lucky enough that it worked out well, but follow your passion. I'm assuming you went into radiology because you really loved it, not because you thought you were going to have easy hours, because you won't. Pick the thing that you find the most intellectually stimulating and fulfilling and do that. And there will be a place for you.
And the reality is, it's like Dr. Sonnen said, it's impossible to predict. It's like the current economy that we're in. It's ebbs and flows. Things constantly change. And I think that, you may, if you focus too much on what the market is going to be for what subspecialty in a few years from now, I think you may be doing yourself a disservice for your future career.
Yep. Here's another one. For an MSK radiologist, how important is it to be good in other subspecialties?
Yeah. So for private practice, I'd say it's important. Now, by subspecialties, I would say, obviously general radiology is really important, right? But what will be required of you just really varies from job to job. So I can tell you right now, I don't do any breast, I don't do any nuclear medicine, I don't do any neuro. I'm trying to think. I do a small amount of peds, but basically my jobs are MSK and general radiology. Okay. And what do I mean by general radiology? So, a lot of the, I would say, advanced body imaging, like rectal MRI, prostate MRI, like if you can come and want to do that and you're good at it, that's fine, but it's not really required of any of our MSK radiologists. We have fellowship trained abdominal MR radiologists as well. Right. That being said, it depends on what setting you're going into. If you're going to a smaller practice, right, where there are maybe less subspecialty radiologists, more may be expected of you. Certainly, if you can advertise having a diverse skill set, that will definitely help your marketability. But I don't think that it's again, I guess the short answer is it's really going to vary from practice to practice.
Right. And that's exactly right. So in fact, I would absolutely urge all of you to put that on your Excel spreadsheet. If you're looking for a quote unquote MSK job, I'm here to tell you that knowing enough of my former trainees and, folks that have joined our group from other groups, just because the job is called MSK doesn't mean that's what you're going to do most of the time. So that's a fair question to ask. about what percentage of my time do you expect will be spent in musculoskeletal, and what else will I be expected to do? So as Dr. Trakhtenbroit said, I haven't looked at a mammogram since my boards. I haven't put a catheter in someone since my boards, but I can tell you there are places where you do that's expected on the weekends or in the evenings. So we're big enough that basically all I do is musculoskeletal, except on the very, very, very occasional general shift. And then on weekends, we're still sort of hybrid. So I don't ever do any interventional. I don't ever do any mammo. I don't do any advanced body. I pretty much don't do any neuro. So I'm looking at plain films and basic ER ultrasounds and CTs, but it's almost all MSK. But we're big. We're 120 plus people. If you're joining a 40-person group, it's going to be different. And you need to ask that question. Now, the other option is go in with the attitude of, I'm going to build an MSK service and I'll make my job more MSK as time goes on. So in some part, it may be up to you. And a related question that I saw, which I thought was really interesting, is regarding the relationship. Oh, here we go. When looking at a group, how can we best evaluate the dynamics with referring providers and how they may impact your day-to-day practice?
Yeah, that's a very good question too. I mean, personally, I think the best way is just to ask some of the radiologists. You know, I actually, I mean, I could tell you, I'm sure Dr. Sonnen can tell you as well. I spend a large part of my day looking at images for a lot of other physicians. You know, for example, now that, you know, Major League Baseball's back on, my phone never stops ringing, right? And it's always an emergency and it's always something. But that's a part of my job that I actually really enjoy, is having those relationships. I mean, you know, I have very good relationships with my radiology colleagues, but probably some of my best relationships and friends are with our referring orthopedic surgeons. You know, we've just worked a lot together time to time. We talk on the phone. And I think the best way to probably gauge that is really just to ask some of the radiologists when you interview for that job and say, you know, do you have a cordial relationship with your referring clinicians? Can you tell me a little bit about that? And I think most people are pretty open and receptive to that.
Yeah, I would absolutely agree. And I would also say that that's one of the differences that I would comment on in sort of, if you will, a difference perhaps between academics and private practice, which is in academics, you are often in a closed system with a university setting and a dean and different departments. And so you're sort of guaranteed to have this business from the orthopedic group in that system. Whereas in most private practices, you have to earn your lunch every day. And so, you know, it's the three A's, right? Availability, affability, and ability. So you have to be able to read the cases well. You have to be available. So every orthopedic surgeon in Denver knows my phone number and has it on speed dial, and they use it all the time. I've gotten several calls while I've been sitting here in San Diego at the annual SSR meeting because they don't know I'm gone. And that's one of those things you give up a little bit, is privacy. Or if you take care of professional sports teams, which I did for years, you give up that, you know, this is my time. You don't have that, but you have to be willing to do that. But that buys you incredible street cred in the market, and that's something that will serve you very, very, very well.
Yeah, and I think, you know, alongside of that, you know, one thing is, you know, we have a couple of young orthopedic surgeons, probably my age or a little bit younger, and they really like to review cases, maybe like let's say the night before they have an OR day, right? And it's one of those things that, you know what, yes, you know what, sometimes it's tedious. Sometimes in my evenings, you know, I'm doing stuff with my kids. But I also know that these guys, they send all their patients to us. And so the amount of business that's being generated from that, just from those relationships, like you said, being available, being affable, and being able, it really is a stronghold for your practice. And Dr. Sonen's right. You know, the reality is, if you're not willing to do that job, they'll just find someone who is. And you know, not everyone has all three A's, but I think just having a positive attitude, being available, being friendly to people, just really can't be understated.
Absolutely. And that, you know, honestly, it should be successful anywhere, but in private practice, your career literally depends on it. We're getting close to the end of when we can sort of be doing this. So I want to paraphrase a couple, and I apologize to those of you whose questions we can't get to, but one question was about switching career. In other words, if you make a choice to go into private practice, how big of a deal is it to switch jobs? And I can just tell you the answer is you can do it. it's not a difficult thing. And frankly, the more experience you have, unless you are carrying, sort of red flags around in terms of, well, he was awful to work with, no one looks askance at you. They'll ask you why you're leaving. Um, but you don't have to, I don't think you have to feel the pressure of picking the perfect job the first time out. It used to be that there was a statistic, the average radiologist changes jobs 4 times in a career. I don't know if that's still true.
Yeah, I can think of a number of people that we've hired since I've been in the practice who have made the move from obviously academia to our practice. The nice thing is, my practice is not as big as Dr. Sonen's, but it's still fairly sizable. And we are very upfront with people about what their expectations are, but they're also upfront with us about what their abilities are. If they say, well, I've been doing academic MSK for the last 10 years. I haven't read this, that, and the other in a really long time. Then we're actually able to accommodate that. We're able to say, oh yeah, well, you're not going to be reading stat CTs from the ER or head CTs or all of that stuff, And so I think that that's comforting for a lot of applicants. Now, that's far from the truth in many places where they'll say, well, you're being hired for this job, you're going to do what everyone else does. That may be the option for a lot of places, but it just so happens that that's not what my practice, and I would say many other subspecialty large practices are doing.
Right. And the trend, I think, the trend really is to larger, more either through acquisition or mergers or consolidation or VC sales or any of those things. That's what the trend is. The trend is toward larger and larger groups with more and more subspecialization. We are a privately owned group. We own the group, and we're never going to sell. That's our mantra, but not everybody agrees with that. But the point is, we have been acquiring other practices. They become partners just like we are. Other places have joined, larger entities like US Radiology and are part of a larger entity. But there's power in scale. Everybody seems to understand that, and it gives you the leverage of a scale of economics that allows you to have more subspecialty coverage later into the day or all night or whatever it is. So we have a neuro nighthawk, we have 2 body nighthawks, we have MSK till 11 p.m. every day, and you can do that when you're a bigger group. But these are all questions you got to put on your list and ask, because don't assume anything. Ask, am I going to have to read neuro at 3 a.m, even though I'm an MSK radiologist? You got to ask those things.
Yeah, and the reality is at least for our practice, some of the most profitable hours are between 7 p.m. to 7 a.m. Right. So it really behooves us as a practice to have that same level of quality in the middle of the night that we have in the middle of the day. So that's why, just like Dr. Sonnen said, yeah, most of our neuro reads overnight are being read by fellowship trained neuroradiologists, right? We have an in-house fellowship trained MSK radiologist every night till at least 11. If our late call week body radiologist is MSK trained, they'll be in-house till 1 a.m., right? So we really do provide those round the clock subspecialty reads.
And as we get to the closing minutes, just there are several questions about, which is actually kind of concerning to me. They feel the pressure about negotiating jobs as residents. And I think that's what's happened is because of the shortage of available people, more and more groups are talking to residents about jobs. And I don't know how to answer that. In other words, what fellowship do I do and how do I negotiate contracts if I'm still in my residency? I mean, we personally have never talked to a resident about a job. We have 120 of us are all fellowship trained. And most of the folks came out of either academics or some other private practice, but we are now hiring a bunch of people out of fellowship. But there is a trend. People are hiring residents and offering various situations. So you guys aren't seeing that right in your practice, Michael?
Not right now, no. Everyone that's sort of been on our radar is usually at the level of the fellowship. And yeah, I'm thinking, how are we going to actually be able to provide that level of mentorship and assistance to residents in this position? I think it's going to be really challenging because that was certainly not the case when I was a resident.
And I think there is no correct answer here. And in a sense, that's the one bad thing you have to deal with as residents now with this really hot job market is they're going to be fishing for younger and younger fish. I think we're going to have to wrap it up because we are running out of time. I want to thank Dr. Trakhtenbroit very much for his time and expertise in this. I think it was a fabulous presentation. It gives you a taste of all the things you need to think about. It is by no means a comprehensive list. Your list will vary by your personality and your needs. I want to thank the audience for participating. These are great questions. I'm hoping he'll provide some email or something where you can get a hold of him to maybe get some follow-up answers, and you can get mine as well from the Veritas people. I'm more than happy to answer any of your questions. I want to give a plug to the next lecture, which is April 20th at 7 p.m. Eastern. It's called Advanced Imaging of the Pro Athlete, and it's by Jeff Belair from Thomas Jefferson University in Philly, who just gave a presentation at the SSR. He was a very engaging speaker, so I hope you'll enjoy that one. Again, April 20th, 7 p.m. Eastern. We hope to see you there. And thanks from San Diego.
And
Oh,
again,
don't forget your survey.
don't forget the survey. And I actually just put my email in the chat box. So if anyone has any questions, I saw there's more questions that we were able to get to. Again, I tried to only speak for 30 minutes because I knew there'd be a lot of questions, but you know, I know it's a challenging time for residents. I'd say it's probably a good problem to have.
Yeah.
But I'm sure it's challenging to navigate, but I will happily answer any questions by email because you know, I definitely want to be able to give people guidance. So thank you for your attention.
And likewise, and I see that the Veritas people posted mine. It's asoninmd at Yahoo. I'm more than happy to email or chat with any of you guys. I love this stuff. So good luck to everybody and take care.
Have a good evening.